I am Philip Hartman, family practice and former SMA president. Here talking with Dr. Carl Fichtenbaum, infectious disease specialist at UC Health, and also one of my favorite infectious disease professors from my time at UC College of Medicine. So, Carl, this all came up when I was listening to the radio and heard mentioned that 50% of new HIV cases in 22 were in the South. I thought about that for a second and thought, that doesn't fit population. So clearly we have a problem. So
yeah.
Where do we as a country stand in treatment and prevention of HIV?
Yeah. Well, first of all, Phil, thank you so much for having me on. It's a pleasure to talk to the members of the Southern Medical Association. I think it's really important to just have conversations about healthcare and general health prevention on any sort of scale in our country. So it's really great. In HIV, we stand in a situation where we've been making some progress on decreasing the number of new infections in some populations, but not in other populations. So, for example, over the past probably 5 to 10 years, we've been having a slow decline in the number of new infections, averaging somewhere between 30 to 45,000 new infections each year. But the number of new infections in the white population has been declining much more steeply, but it is not declining in the Black or African American population or the Latino, Hispanic, or Latinx population. So, and we think that the main reason why this is happening is that the uptake of what we call HIV pre-exposure prophylaxis, or as it's known, HIV PrEP, is much higher in the white population, particularly men who have sex with other men. That population has been much speedier to utilize that resource, and therefore it's been preventing new infections. That's why we're seeing a decline. But the same is not true for other groups that have historically had less good access to medical care.
How well does PrEP work?
Yeah, it's really good. So the original studies that we did were with pills. And what we found was that the original New England Journal Medicine article where we used tenofovir disoproxil fumarate, TDF, known as Truvada when it was combined with FTC or mitracytidine. When we used that medication, it was about 44% effective. But when we actually looked much closer, if you actually took the medicine, it worked very well. And there were a series of studies where up to between 80 to 90% or so of people who actually took their medication every day were able to prevent HIV transmission. So that was a win by just using pills. There was subsequent studies where they used a different formulation of tenofovir known as tenofovir alafenamide, which is a little bit safer because it has less of the bone and kidney side effects of the older version of tenofovir. And again, the studies got 90% plus prevention effect. So we even have other kinds of PrEP now that's even easier, where we can actually give an injection every 2 months of something called cabotegravir, and that is highly effective. And what we see is upwards of 95% protective efficacy. So we have tools now that we can utilize in our toolbox to prevent HIV transmission with about a 95 to 98% efficacy. And of course, like any other tool, it's dependent on its use. As long as people are using it correctly and using it in the right timing, it seems to work very well.
Now, those tools, is there any racial or ethnic disparity in how well they work?
No, so there's been a number of studies. Some studies were restricted only to Black MSM, men who have sex with men. And in all of these studies, the success has been the same. And what's even more heartening is that there's no difference in side effects. So if you're young, if you're old, if you're Black, you're white, if you're Latino, if you're Asian, it really does not matter. We're seeing a very broad, good effect in preventing HIV transmission. And we're also seeing limited side effects. So, and they're manageable.
What kind of side effects?
Yeah, so when you take pills, one of the things that people notice is gastrointestinal upset. So there's a little bit of nausea. Sometimes people have bloating. Sometimes they have a decreased appetite. And actually, the tenofovir of the Truvada version, the TDF, has some weight loss associated with that, which may have something to do with appetite or some of that GI upset, where people tend to lose on average about 2 kilograms in a year. Now, if you use the tenofovir alafenamide version, we don't have that. That's a little better tolerated. And there may be lesser of those GI side effects, but there also may be other hidden molecular mechanisms which may explain the difference between weight loss of one version versus another. The TAF version, or tenofovir alafenamide, appears to be fairly neutral in people without HIV infection. They don't seem to lose weight. They don't seem to really gain weight.
Okay.
Some of the other side effects that are less common, but we have to be concerned about them. So with the Truvada version, you can also have a little bit of bone loss. It's somewhere between 1% to 2%, a little less than what might be seen in a woman who goes into menopause, where they have between 2% to 4% of their bone density lost. We see less of that with the tenofovir alafenamide or Descovy version of that. And then with the kidneys, there sometimes is more side effects, again, with the Truvada or tenofovir diprovoxyl fumarate version. We see a Fanconi's-like syndrome. Sometimes there's spilling of glucose and protein in the urine, and occasionally you can see hypophosphatemia. And very rarely can you see actual increase in their serum creatinine or a decrease in the glomerular filtration rate, or estimated GFR. Those are the most common side effects that we see with pills. With the cabotegravir, those injections can be somewhat painful when initially given, and they can sometimes leave a little lump or area that hurts. It's given in the gluteal muscle right now. And sometimes people have a little bit of trouble sitting on that spot. Usually that's about 1 to 3 days. And most people, that's tolerable. And the people who opt for that often opt for it because then they don't have to remember to take a pill every day. And for them, there's been a lot of studies where they said, yeah, it might hurt a little bit, and there may be a little bump at the injection site, but usually it's pretty tolerable. So there's a couple of caveats. One is that you want to have people who have enough muscle mass. So if you're very, very skinny, that can sometimes make it a little bit more painful. And then two is for people who there's a lot more of them to love, or as we know in the South, we have some issues with a larger BMI or a little bit more obesity. You have to be careful about making sure the injections actually get intramuscular. And some of the little tips that I talk to clinicians about are looking at the size of the buttocks when you have people who are 35, 40, maybe 50 BMI, that you may need to get a slightly longer needle, 1.5 inches, maybe 2 inches, sometimes, to making sure you're injecting with what we call a Z technique into the muscle. That allows for better deposition, less side effects, and more consistent absorption. And that's actually very important because we've noticed there's an occasional few people who fail treatment, and one of the issues may have to do with body size, body weight, and making sure that the injections are actually getting intramuscular and there's appropriate pharmacodynamic and kinetic distribution of the cabotegravir to protective levels.
Now, is that a polymer-linked drug, kind of like the naltrexone and Vivitrol or Bydureon's GLP-1?
Yeah, so it is. These are depot medications. And in fact, if you take an injection, there can be lasting medication for up to 48 to 52 weeks. So if people decide they want to stop injections, it's really important for practitioners to know that there's a tail, and that tail represents an opportunity. If they come in contact with HIV, become infected, they may have subtherapeutic levels of cabotegravir and develop integrase strand transfer resistance to cabotegravir from their HIV. And that then leads to a situation where they have a limitation on choices of how to treat HIV. So that tail is important, so we can explain to patients, hey, if you decide the shots aren't for you, you want to stop, we really need to give you about a year's worth of the Truvada or Descovy medication that you should take so that you don't catch HIV and then develop a resistant strain of it that would limit your ability to use medication to treat it.
That would be important. So listen into that side effect profile. It's not tremendously different than that GLP-1 that I talked to you about, or even necessarily worse than some of the blood pressure medicines we're also comfortable writing.
Yeah,
Yet
I think
not many physicians comparatively write this. Would you say that's fair?
Yeah, I think that the scary factor has been, boy, I don't treat a lot of HIV. I'm not very comfortable or familiar with these medications. They have really strange names. And I wonder whether there's bad side effects or I might do harm. But in fact, you're right. These are not terribly different. And from a side effect profile, not really that much different than something like lisinopril. We see patients who develop cough all the time with lisinopril, but primary care practitioners know how to manage that. We see people who develop an elevated serum creatinine or potassium problems with lisinopril, and practitioners know how to manage that. So I think with PrEP, although it's been kind of scary thinking about this, I think that that's one thing that people can be reassured about, is that the side effect profile is very manageable. The other piece is, though, is just managing the HIV prevention discussions and the other STI prevention discussions, and then the diagnostic tests that are recommended. So, the CDC has come up with guidance for how to manage people. And there's been recommendations of people coming in every 3 to 4 months to have testing done. Now, if you have somebody on pills, it's pretty easy to have them come in every 3 months, and they can get tested to make sure they have an acquired HIV infection or other sexually transmitted infections. And you can just talk about healthy, lifestyles and things, or about prevention of diseases, because there are other preventable diseases like gonorrhea, chlamydia, HPV, syphilis, that we don't want people to catch. And so encouraging people to use condoms is helpful in some ways because it does prevent other diseases. And if you have people who are coming in for injections, they come every 2 months. So on those 4-month intervals, you can be measuring them for HIV as well as for other sexually transmitted infections. So I think that it seems a little complicated, but there are good websites. The CDC has a very nice page of guidelines, of recommendations of testing. And there's only been really a few controversies. So one of them is, what kind of HIV screen testing should one do? Most insurance and many programs and states will pay for HIV screening with antibody testing for sure. And many programs will pay for a qualitative HIV test. The problem is that a qualitative HIV PCR test may not be sensitive enough when people are on injection therapy. We've noticed there's a handful of cases, probably, somewhere in the neighborhood of 1 to 3% of individuals who have breakthrough infection. It's called the Levi syndrome. Now we came up with a name for it. And these are people who have low expression, low viral expression. And so their viral loads may be somewhere in the neighborhood of 500, 1,000, maybe 1,500 copies or less. And their antibody tests don't immediately turn positive. So if you do a rapid HIV test, point of care test, it may be negative. If you do an antibody test, it may be negative. And the only test that really might be positive is if you do a quantitative HIV PCR. And the only problem is that insurance doesn't always pay for that, because that is thought to be an HIV treatment test. And so it's more restricted to people with HIV infection, as opposed to an HIV prevention test where people think more about, well, test for antibodies, because that's the traditional historic way that we've looked for HIV. So I do think we have to change a little bit. I think a practitioner needs to check just a little bit in their area. If I order an HIV quantitative PCR for my patient who's on HIV PrEP, will that get paid for by their insurance or by a state program? Or will the patient be on the hook? Because those tests are very pricey, can range from anywhere from $250 to $500, sometimes $700, depending on the lab. And usually we don't like our patients to be saddled with something that they don't expect.
Especially 4 times a year.
Yeah.
If you're getting those every 3 months. So, and I had always thought of the PCR from a primary care perspective. That was my go-to if I was suspicious for acute HIV based on a clinical presentation.
Right. I think what we've learned recently is that cabotegravir, because it has very good levels, if somebody is in the midst of seroconverting and we don't know that, and we start them on HIV PrEP, we've seen in the first few months, those people will seroconvert, but it's delayed and it takes a while and their levels are very low. Then we've also seen the other people who've been on it for a while and they've had pretty good injections. They've kept all their visits, but for whatever reason, they may not have a great distribution or high enough levels of cabotegravir where they need to be, and they acquire HIV infection. And again, those people, the antibody testing is delayed. It often takes 3 to 6 months before you even start to detect antibodies. And they have very low levels of HIV, and their qualitative tests may initially be negative on a PCR, and only the quantitative test may be detecting a few hundred copies. So I think that's really important for people to understand that so that depending on what kind of prep your patient is on, you may need to do testing a little bit differently. We have not seen that so much of a problem with the oral prep. So I think if people are using pills, the standard sort of point of care, rapid testing, confirming with an antibody test every 3 months seems to be pretty reasonable to do.
Now, with the risk to benefit consideration here, if that part was making a provider afraid to write this or uncomfortable writing this, it sounds like you would miss for one test in the highly unlikely event that your patient converted while on the injection, if you were doing
Yeah.
every 3 months.
Yeah.
So I would hope that wouldn't stop people who were considering it from going through with it, because your relative harm should be very low
Yeah, I
compared to
think,
what you're benefiting.
yeah, and I think in the right population, I think that's the real key here is having conversations with all of your patients. And I think that, much like what people do say, hey, how's your health been? Are you doing okay? Okay, let's talk a little bit about any health risks you might have. Do you smoke? Do you drink out any alcohol? Do you use any other non-prescribed medications of any kind? Do you wear your seatbelt? If you have a gun at home, is it kept safe and all that kind of stuff? Hopefully there's no trees at your house are going to fall on you. And by the way, let's talk about sexual activity. So, who are you having sex with these days? Is there any risk that you might be acquiring any kind of sexually transmitted disease? And I think that that's important to ask those questions, and also to tell people, hey, are you just want to make sure you're also having a, appropriate, healthy sexual life? Are there any problems occurring? Because, some people do have erectile dysfunction and other things. And so, some people, want to talk about their health in general. I think if practitioners just make that part of screening, you can talk to people about this. So if you have people who have a man who is having sex with other men, they are at very high risk, and PrEP would be recommended. If you have someone who is having sex with numerous different partners, more than 3 or 4 per year, that may be a higher risk situation. If people are having sex with partners that they're not as familiar with, so more anonymous sex, that may also place them at higher risk, since they don't really know about the health of those individuals. If they're having any sexual activity with individuals who have HIV infection or are injection substance users, that may also be a higher risk. So doing a little bit of questioning and investigation sometimes gets you into a situation. And then, of course, the other key factor is, has your patient had a sexually transmitted infection in the last year? Anyone with chlamydia, gonorrhea, or syphilis is at much higher risk. The HPV story is a little bit less clear, because HPV is far more common in the overall population. And also herpes simplex virus is also very common. So those viruses don't always correlate quite as well. But certainly chlamydia, gonorrhea, or syphilis would be a big indication to say this person may be at higher risk of HIV acquisition, and therefore, have you thought about PrEP or considered it?
Can some of those change the transmissibility of HIV as well through cervicitis and such?
Yeah, so if people do have an active infection, there is recruitment of a number of inflammatory cells to the surfaces of the mucosa, and those cells become activated, and they are far more permissive for HIV infection. So basically what you're doing is you're bringing the cells that are most likely going to swallow up or scoop up a HIV right there, and they're very activated. So if you look at many, many different epidemiologic studies, yes, people are at higher risk of HIV transmission. The other situation where HIV transmission is much higher, and this is a different, more unique population, are pregnant women. And so are women at higher risk? You know, I don't want practitioners to walk away from this thinking, oh, I should only be offering this to men. No, it turns out that women may be at higher risk. So you need to ask women about, well, tell me a little bit about your sexual partners. And, you know, have any of them been HIV tested? Do any of them have sex outside of relationships? Do people have open relationships? You know, so I think you have to get that, because we are seeing about 1/3 of new patients that are being infected are women. And this is particularly heavily true in the Black or African American community, where about 70 to 75% of new infections in women are occurring in that community. So there has to be some discussion and consideration of HIV prevention, because it is helpful in that population as well. Now, I think a couple of caveats there. The Truvada, we know, works in that population. We have less information about the effectiveness of Descovy, and there may be some differences in how it is metabolized in the cervical and vaginal environments, and it may not be quite as protective. We do know, however, the cabotegravir is very effective, so injections work as well. So again, when you're thinking about women who may be at higher risk for HIV transmission, those may be in situations where they have a partner with known HIV infection where it's not controlled. And then there also may be situations where people may be sexually active or have sexually transmitted infections, or have very frequent partners, in which case they may be at higher risk. And there should be a shared decision-making discussion about whether or not HIV PrEP makes sense.
So who is eligible for HIV PrEP?
Yeah, so anybody, I think, when you start thinking about people who are sexually active, it's anybody really, you know, above the age of 16 or older. You really start to think about it. That's where you need to start looking about who might be eligible. And again, it is really a risk-based discussion. So what are the risks for that particular person? Do they have a history of having sexually transmitted infection? Do they have a history of injection drug use? Do they have a history of having sex with higher risk situations, men having sex with other men, women having sex with partners who may be HIV infected, or having frequent partners, at least 3 or 4 or more per year, may place them at higher risk. And of course, anonymous sex, and then some rarer circumstances where people may have sex in exchange for money or for, you know, commodities or other things, that may also place them at higher risk. And those would be situations where you may want to think about HIV PrEP.
Great. So if we have somebody who's an injection drug user, 3 to 4 or more partners per year, any anonymous partners, any MSM, and any transactional sex, those would all be, and a history of sexually transmitted diseases, those would all be eligible for PrEP.
Yeah, and I think the one population where we're still doing research and trying to figure this out and generate a little bit more data are strictly the injection drug use population, where we don't have as much information on how effective PrEP is. And I think that's been historically a harder population to study. And so there is some controversy. So I will go, you know, on the record saying that as a practitioner, I believe this is a good strategy to use, because I think the risk of HIV transmission is quite high in this population. But the data, the scientific information on prevention is not as strong as it is for men who have sex with men and women for heterosexual transmission, for men to women or women to men, where we have better data in longitudinal studies where we've proven beyond a shadow of a doubt that it's beneficial. So I
So
still
then,
recommend it for the injection drug use population because I'm just an old school doctor who believes an ounce of prevention is worth a pound of cure.
for sure. And I would imagine too, from an insurance perspective, if they say we won't cover it for just injection drug use, if they are also sexually active, there's a very high chance that they're sexually active with someone who is an injection drug user. And that would be a high risk sexual behavior, which should get coverage.
Yeah, I think that's really true. And you sometimes have to look into those things for sure. I think it's also an opportunity now that some of the rules have also been relaxed to talk about Suboxone and trying to help your injection drug users as well. I don't want to heap too much on primary care practitioners, but I do think it's an opportunity to begin a conversation, and that has been very beneficial. And I've been doing that in my practice, really trying to help people out with some of these dual epidemics that we see. It is a lot harder to treat somebody who has HIV infection. And, you know, it's not particularly easy, and it's still costly to treat hepatitis C infection, which is very, very common in the injecting drug use population. So I think it makes sense to me.
Yeah. And as a primary care doctor who's fully aware how much has been heaped on us, to me, this is just as much a part of their primary care as checking their cholesterol. And I've had providers before that when I bring up treating substance abuse, because I write naltrexone to treat substance abuse, I write acamprosate to treat alcohol abuse and naltrexone. Um, I've had providers say, "Oh, I don't treat those patients," and I've looked at them before right in the eyes and said, "You are wrong. You don't ask your patients the questions to understand what's harming their health, but you do treat those patients. You just ignore these issues." So I think being comfortable having conversations about this is really on us as providers. So that's part of our job, because when we're comfortable asking the questions, our patients are more comfortable giving us the answers.
Yeah, I agree. I agree 100%. And I think it's really a part of just overall health prevention and really thinking about things. And I think that that's, you know, what healthcare providers should be for. And I do think I would advise, you know, primary providers in any neck of the woods to, you know, find yourself somebody as friend who may be an infectious disease expert or somebody who has experience that you can say, hey, listen, if I have any questions, is it okay if I give you a shout or give you a call? I think there's enough of us around that we're very comfortable saying, oh, sure, yeah, you know, if you need any help or assistance, be more than happy to help you. You know, and there may be unusual questions that come up or odd situations on occasion. So it's nice to have that backup as well. And then once you've been doing it for a little while, I think most people get a bit more comfortable and they'll develop their own experience and expertise. And then they'll become a part of the, you know, fabric of HIV prevention, which is really important.
Now, one thing that we always, in primary care, one thing that's sort of the bane of our existence is coverage. With PrEP, what does coverage look like currently for
Yeah,
insurances?
so it depends state by state. So there are some states, for example, where some of their assistance programs and state programs have been providing some coverage. And insurance has certainly been very good about providing coverage. So if you have working people who are insured, then usually you can get coverage. The other thing is that the companies who have really been advancing this are very good about helping and assisting people. So both Gilead and Vive have representatives, and they're easy enough to contact in people's areas. And there's usually different representatives by state or region. And they're more than happy to help patients navigate this. And they have some fairly generous programs to help provide PrEP to individuals who may be eligible for it. So it's not every circumstance, but they do have programs that help not only with providing it, but also helping with some of the copays that may be part of the issue that comes up with any sort of health insurance. So I would urge practitioners to think about that. And it's pretty simple. If you go directly to their website, there's usually a patient assistance tab, and you can just click on that thing, and you can have your patients help with that. And some practitioners have other specialty medications that they work with other provider level folks. Pharmacists sometimes are very, very helpful in navigating prior authorizations and also referring people to company programs that can help provide either assistance or copay assistance. So I think in most circumstances, we've been pretty lucky about being able to get that. Now, that being said, not every state is like that, and I'm not an expert on every state. So if we think about the Southern Medical Association, thinking about Mississippi, Louisiana, Alabama, I think people need to do a little bit of their homework and look in their own state to see what may be covered, what may not be covered.
So it's my understanding, as far as the South goes, from something I heard recently about a current court case, that as things stand today, the Affordable Care Act requires coverage of preventative care, and these are included. Now,
Yes.
there's a state that's bringing suit right now to see if there can be carve out based on things people might find morally unacceptable. But I think as of right now, the southern states should be required to comply as well. I like what you said about looking at your resources. So a lot of us feel overwhelmed in what we have to get done on a day-to-day basis as is. Finding out if you have a pharmacist, a social worker, a care coordinator of sorts in your environment that can do this. And I would even suggest for people who might actually still be in private practice and don't necessarily have those available, reaching out to the drug rep and finding out if they would be willing to help do some of the legwork.
And they do, particularly in the southern states, there's been an initiative to make people more available. And so I think all of those resources are helpful. So it just depends on your particular practice setting and whether you have any provider extenders or other people who you work with on a regular basis for prior approvals or other medications. I think if you talk to most physicians, they're pretty well overwhelmed by the paperwork in general. And most of us have people who are helping. So in our large practice, where we have probably one of the largest HIV PrEP programs in the state of Ohio, and particularly with cabotegravir, we have a pharmacist who I worked with to help set up the program and run it. And it's really run very efficiently by pharmacists without us having to do very much other than signing orders and helping to do some of the medical co-management. So, it's a win-win situation. There's a lot of education that can go on as well behind the scenes to help people, and a lot of questions that can be answered by other providers as well. So I urge people to think about that. And yes, I do think that the pharmaceutical industry does provide some help in this regard, particularly for those in private practice or solo practice where they may have less resources available to them.
On a somewhat, but not that tangential comment, for a fellow that you've got going through your program, that could make a great paper write-up, the program that you put in place to help find coverage. That's something that I could see a journal taking up to say, hey, people could use this information to make their practice life better and to help provide better care for their patients.
Yeah.
Um,
Oh, yeah. Yeah.
Now, another thing, when we come to HIV prevention, a lot of us have seen the commercials and read articles that undetectable can mean untransmittable, which brings up the question, how much could we be doing to prevent transmission of HIV by screening the appropriate people and getting them on treatment,
Yeah.
referring them if we don't do it ourselves? How should we decide who to screen for HIV?
Well, I think that every human being who's more than 15 years of age ought to be screened at least once in their lifetime for HIV. And depending on any additional risks, they may need more frequent screening, as often as, perhaps annually if they're practicing higher risk behaviors. So I do think it's very important because we think that, there are still probably 20% of people who have HIV. Some of those people don't recognize that they do, and some of them are just not in care. And they are a part of the issue that's leading to further HIV transmission. And you are absolutely right. U equals U, undetectable equals untransmittable. So if you have a viral load that is less than 1,000 copies, most of the studies we've looked at, the risk of transmission is incredibly low. If you are undetectable or below the limit of detection, there really are no credible studies that have demonstrated linked HIV transmission. So one of the best treatments we have, we call this treatment as prevention, or TASP. And it really is a very effective tool. So screening people for that, and then, while you're in the neighborhood, screening those who may be at higher risk for hepatitis C, and certainly those who are in the baby boom population, those, anybody between the 1940s, 1970-ish range, that's a group that may be at higher risk for hepatitis C that was undiagnosed. So, I think it's just an important thing to do and to sort of normalize, and it's a great primary prevention thing.
And if we have people who are reluctant to take that up because they think their patients will be offended to have it suggested, I tell my patients that that is the stance of the U.S. Preventative Service Task Force. And that's who I go based on for everything else I'm giving them guideline wise. So I try and remind them that if everybody got screened once, no one would have it and not know. Now, there is the lead time, so that technically wouldn't be no one, but sometimes we have to be a little broader strokes than the nitty gritty when we're talking about it with patients.
Yeah, I think it's choosing your words wisely to say that, my job as a healthcare provider is to talk with you about your health and wellness, and to talk about minimizing risks of anything that might interfere with the quality of your life. And so I'm going to talk to you about a broad range of topics, and it's not any way, shape, or form a value judgment about you or what I think about you, but it is my utmost respect for you that I am going to talk to you about risk reduction and risk prevention and screening programs. So I'm going to screen you for heart disease. I'm going to screen you for cancer. I'm going to screen you for risks for sexually transmitted infections as well. And then I like to inject humor in things, and I say, hey, the strangest things always happen, and we sure see this a lot on the movies. So, it sometimes happens in real life. And so I think it's always worth doing. And then if all else fails, I always use the great fallback notion that, there's a lot of quality measures that are assessed on me as a provider these days. And so in order for me to look good, I just need to be able to screen my patients so that when the bean counters come and check, am I doing my job? At least they'll know I'm doing my job and I was doing the right thing. So I apologize if that may offend you in any way. And most people can look on that going, oh yeah, there's somebody over everybody's shoulder doing that. And so that usually works pretty well. So, and that's not something that you always have to do on the very first visit with people. You can establish some rapport. There's never an emergency to do these things. And if you get into a few visits with people, that's a good time to be saying, hey, let's have a little bit more conversation about some other risk prevention and screening things we can talk about. I think people are pretty open to that as long as your conversation is a nice conversation and there's really no judgment attached to it, and that you really are having their best interest at heart.
Absolutely. I like to tell people that it's my goal that you are healthier than you would have been if I hadn't been your doctor. So
Yeah.
I tell them the more I know about you, the more I can customize your care for you and make sure we get everything you need done. And then I'll make little comments as we go through, like, I always ask them, where do you work? Okay, and what's your position there? Because sometimes it's pertinent to disease risk. If somebody says I'm a plumber and they come in with a cough, I might think more about asbestos exposure than I would if they said I do taxes.
Yeah.
But I also tell them that when I see things in a chart, like an occupation listed, or when I see that all of their first degree relatives have been added to their family history, that's a way that I know I've been in your chart. So I can look at it and say, okay, if I've got this in here, I've been in this, I've done a well visit with you because I've gone through all of it. And I find too that, like you said, not having judgment on the way you ask it. I can ask you, are you sexually active? Okay. Are you active with men, women, or both? How many partners have you had in the last year? The same as I could ask you, hey, I'm going to run by McDonald's. What would you want me to pick up for you? And there are times that we'll have talks about what they say. And again, I try and say non-judgmental, but risk reduction. I'll say, okay, so 4 partners in the last year, or any of those with protection. Okay, were they with protection every time? And for my teenage patients, they've gotten sick of hearing me talk because I always start after we kick the parents out with, do you wear a seatbelt when you're in the car? Do you wear it every time? I tell them the talk is going to get more sensitive as we go. And if they are sexually active, I ask, do you use condoms? Do you use them every time? And if they say yes, I say, great, because you understand condoms are like seatbelts. If it's not on, you're not protected. I say this part with the car too. And if you knew ahead of time when you would have been in a wreck and really needed it, you would have never gotten in that car, right? And I love it when they come back the next year and say, I know condoms are like seatbelts. I'm like, yes, I got through to one. But I think continuing to build relationships and have those conversations, I think it's become more and more rare as years have passed when people actually do get offended when I ask those questions. And if they do get offended, I say, look, I never want you to leave here and have the care you get be something that if one of my family members got it, I'd say you have a crummy doctor, you need a new one. So I always need to make sure that I provide you a level of care that would be acceptable for people who I love and care about. And if it's not, then I shouldn't be providing it at all. And that tends to diffuse things pretty quickly too. But to recap, there is a disparity regionally, ethnically, racially in new HIV infections. There is not a disparity on any of those levels in the way in which the preventative items we have for this work. So we either have a disparity in uptake, access, or provider comfort. And I do think that we as providers can alter uptake. I've had people take vaccines that have come out recently that they told me first they'd never take. And then after a conversation, they say, all right, are you telling me I need this? Okay, I trust you, I'll do it. We use what I call my social capital, the relationship I built with you to help you be healthier. So hopefully we've gotten through to some providers who've listened to this who say, you know what? Okay, I'm willing to get my feet wet. I will start asking questions. And when it comes up, I might start writing this medicine. So if somebody wants to start writing it, they've identified the candidate, they've had the conversation, the patient goes, yeah, I'll take that. How do they get started?
Yeah, I think the simplest way to do it is to say, okay, let's do some tests to screen you today and make sure that you're okay. And that would be, we usually recommend a screening CBC with differential, a renal panel, so that you can see what their kidney function is. I would recommend a urinalysis so that you can just detect if this person has any unseen protein or glycosuria, because that might influence how you, interpret any later side effect. I would do the HIV screening and, of course, screen for hepatitis B, because if you treat somebody with these medications and then suddenly stop them, they can have a reactivation of hepatitis B. So once you've screened for HIV, hepatitis B, and you've done some general screening, and they do recommend chlamydia, gonorrhea, and syphilis screening at the same time, then you can tell people, okay, now let's talk about what options there are available. And we have the Truvada, we have the Descovy, depending on the individual, and we have the cabotegravir that are all FDA approved. Talk about which one fits them best for their lifestyle, and then say, okay, we need to go through the prior approval process. So oftentimes I will do all the screenings and try and say, let's go ahead and try and order the medication through a pharmacy that they're going to use, and go through that process so we can see what it is. And once we get everything back, that we know that there is not any undetected infection that we happen to miss, then we can go ahead and initiate therapy. And sometimes it takes a week or two, depending on the prior approval process, for them to get the medications. So that's my strategy that I typically employ. And then we talk about side effect profiles. We talk about what to do if they have a problem, and that they should contact the office or contact me so that we can discuss it if they're concerned that they're having a side effect. And then schedule them back for follow-up, usually in that 3-month window. Or if they go on injections, it might be 4 months, so that we can repeat some testing and also check in to say, hey, how's it going? Everything going okay? Now, as a practice in general, whenever I start a new patient on something, I usually like to have that follow up in 2 to 4 weeks, either electronically, verbally, or so, just to check in and say, hey, everything going the way we want it to go? Any side effects? You tolerating the medication, and is it having the effect we want it to have? In the case of blood pressure medicine, hopefully maybe they're checking it a little bit at home. And in the case of this HIV prevention, it's not so much that they're checking it at home, but that we are just checking in about side effects, and then we screen them the next time we see them.
Yeah, I find that compliance often goes up when touch points go up as well, which can be helpful.
And if you
And
have
for
physician extenders, you can have them do that too. Just check in 2 weeks to say, you doing okay? If they got a new injection of cabotegravir, check in 2 weeks. How's your backside feeling? Everything good? You're doing okay? Great. Talk to you soon. That just shows general interest. It opens the conversation for any side effects. And I think it's just a good way to practice medicine.
absolutely. Um, so to recap that part, that is not any harder than starting most of the diabetic drugs that I start.
I would agree.
So we have available and effective treatment. If we're willing to have conversations and willing to start it, we could have a big impact on the transmission of HIV. And one thing I'd like to point out for providers is that when we start talking about who would be eligible in a population, this isn't like checking blood pressure, where I'm going to find a huge percentage of my people who turn out to have high blood pressure and I need to test them. So if someone's going to get their feet wet, it might be with just a patient when they first start too, which might be a lot less intimidating for a primary care provider. I find that not every time I bring this up does a patient even say, okay, fine, I'll take it. I've had some of them who come back 2-3 years later and they say, hey, I'm here to start this. You talked to me about it before and now I want to start it. Which I always welcome back. That's, again, to me, it's kind of like the teenager who remembers that I told him condoms are like seatbelts. That says, hey, something I said stuck with you. So I would say from a primary care perspective, because I do consider prevention of disease to be the bread and butter of primary care, I hope most do, that if somebody decides they want to write this, it's not like they're saying, okay, I'm going to have 100 people on this now, and I'm going to have to follow 100 people for this. They're probably going to end up starting a relative small number when they start having these conversations.
Yeah, I think the reality is for any given primary provider, unless they have a specialized practice where they're attracting a certain population, you may start out with just a handful of people and maybe you wind up with, 20, 30 people at most that you're managing this on. There's not huge numbers when we look at estimates of people at highest risk for HIV infection. In the United States, there's probably, a pool of between, 10,000 and 100,000 people in a country of 330 million plus people. So, every practitioner, it's going to be a small number and usually a manageable number. And yeah, I mean, we're trying our very best to decrease the number of new HIV infections. And this is a great way that somebody can do primary prevention. And you're absolutely right. When people are faced with these decisions and discussions, not everybody always perceives it's me. They don't always see myself as high risk. Nobody walks out the door thinking they're going to have a car accident, but yet those things do happen. So, in the same way, people just don't always view their own risk that way. And people do question sometimes the need to take pills every day. And, does that mean that I'm a sick person? And there are also confidentiality issues about who they may live with and what that means in terms of disclosure. So sometimes those can be conversations, but, I think it's all worthwhile.
And I did not plan this way. It just so happened that I heard that news article and that today was the day we sat down to make this podcast. But we may also have providers listening during this Pride Month thinking, how do I include my patients who are part of the LGBTQ community? And having talks about sexual health is a great way to make people feel included.
Yeah, absolutely.
And like I said before, we may have providers who go, oh, I don't really provide LGBTQ care. They do. They absolutely have patients in their panel who are LGBTQ. They just may not have discussions about it, and they may not be providing the appropriate care. So I always try to remind people who think, oh, I don't really care for that. Well, you do if you're providing broad spectrum care to a diverse group of people. You're caring for that, whether you know you are or not.
Right.
So hopefully this will leave some people comfortable initiating that talk about PrEP. Real quick before we sign off, are there other things from an HIV prevention perspective other than PrEP that we should be looking for, pushing for as primary care doctors?
Well, I think that the biggest thing is if you happen to be co-managing or co-caring for someone who is HIV infected, and they're aging, that there are a number of different conditions that one has to think about. And primary providers should really be keeping an eye open for primary prevention for cancers, cardiovascular disease, bone loss. There are neurocognitive problems, mental health problems. So there are a number of issues that are well within the bailiwick of primary care providers, and it's good to really think about those primary prevention things, and maybe offering people the things that they may need, smoking cessation or other risk reduction and cancer screening that may be useful in that population.
So essentially, my patients with HIV who are compliant with treatment are much more likely to die a death related to something I could have helped prevent or treat than to die an HIV-related death.
Absolutely. And it looks like it's something that might occur, 10 years earlier, whereas people they're aging with grace well into their 70s and 80s right now. Maybe that's more like 60s and 70s with people who've been living long term with HIV. So put your primary care prevention hat on and do everything you can to help people to age with a good quality of life gracefully and be as healthy as they can for as long as they can.
Perfect. I think that is a great place to close it, unless you had other points that we didn't hit on.
No, I just wanted to thank you again, Phil, for the opportunity to talk with you. It really is gratifying knowing that you and I had conversations years ago and that you're a great practitioner now. And I'm sure the Southern Medical Association has really benefited from your expertise and knowledge over the years.
Well, thank you very much. And I really appreciate you taking the time out of your schedule to talk with us. I'm glad to say that I was right when I said I thought you'd be excellent for this and help get these right points across. So I hope you have a great rest of your day, and I hope this really reaches some of the people who hear it.
All right. Take care. See ya.
Thank you. You too. Bye.
Bye.